So look, as you were away, so we started the live stream. So we're now live streaming, but we haven't started the webinar. Okay.
Right. Sure. And so, is this webinar will be made available? Like, you'll host it on the website for a while, so that people who aren't joining us can.
Yeah. So usually I take one day because it's nighttime. So tomorrow morning I'll pick up and I'll have to just make a few editing on the video, but then it should be live tomorrow.
Correct.
In 15 hours or so.
And Luke will ask Megan and ISPAH to add it to NCOIS and ISPAH websites as well.
Okay, so I'll send you the links and then they can do whatever they want. Okay. So, and I see it's live, so it's working. I'm the only one watching at this point.
Oh, there's me.
I don't know. It's you also. Okay, so it's. And I think the questions people are. Can I make some questions? Tepi, are you able to see this testing chat here? Live
yes,
chat?
got okay. Got you.
Okay.
Yeah.
Okay, great. These systems are getting so much better because of all the stress that they were put through this last few months. So I recall that this webinar thing or the live streaming was quite complicated to handle, but now it's quite smooth. Great. And Taren also, so when I start, if you click on the participants icon, you can then see how many people are joining in. So as soon as you start seeing the numbers going up, I would say 50 or something, then we can start. Okay. For now, we don't know if anyone is trying to join in already.
And of course, that is about the time to start this webinar. The tree picking up facility is outside of my door. It's like, okay, this is great. I hope you all can't hear that.
No, it's fine.
Okay.
And Taren, are you, I'm just, because I see the toolbar, the Windows toolbar, are you doing your presentation? Is it working when you move around? Can you test it? Because it usually, okay, it's working here. Okay.
Thank you. I need to use not my keyboard key. I have to use the clicker. So that, I'm glad you said that.
Okay. So on the 58, I will start the webinar. Okay.
Okay.
So that we will have this going on. Again, thank you so much for doing this. I'll be in the background. If something is needed, I'll try to help. I usually say this, I'm not an IT person. I'm a professor also at the university. So I try to do this on my spare time. But I usually, I'm able to sort things out. Okay, guys?
Thank you.
So break a leg and I will say action in 3, 2, 1, and I will start the webinar now. It's live.
Hi, everyone. We're so glad to have you joining us. We're going to give another minute or so for folks to continue to jump on the webinar. We'll start right at the top of the hour. All right, we are at the top of the hour, so I'm going to kick us off. My name is Dr. Taren Swindle, and I'm the chair for the Implementation and Scalability SIG for ISPAH. And we would love to have you as part of our SIG if you're interested in implementation and scalability issues. We're a very active group, and I very much enjoy the work that we do together. We're hosting a webinar today on designing and undertaking implementation trials, and Dr. Luke Wolfenden will be presenting that for us. I'm also joined by Dr. Nicole Nathan, who will be helping to moderate questions, as well as Teppy McLaughlin, who will be helping to moderate our questions as well. Just a couple of housekeeping issues as we get started. The webinar system you all are likely very familiar with by now, but just a quick reminder to use the Q&A function for submission of questions rather than the chat. So we will be able to track our questions better if you'll use that function of the Zoom. You can also raise your hand when we come to that portion if you prefer to interact verbally with us today. We are co-sponsored event today, and so we'd also like to recognize, in addition to our SIG, that the International Society for Physical Activity and Health is a co-sponsor of the webinar, as well as the National Centre of Implementation Science in Australia. And so wonderful folks to follow on Twitter. Implementation Science is a really great community on Twitter, so I encourage you to find them there. I also want to remind you that there will be a feedback survey for today's time, and we encourage you, maybe you can go ahead and snap a shot of that QR code, bookmark it in your phone, and you can come back to that at the end of our time. So without further ado, I'd like to introduce Professor Wolfenden, who received a recent promotion, so our materials were a bit out of date when we were advertising, but Professor Wolfenden is a behavioral and implementation scientist, and he is the director of the National Center for Implementation Science, and that's a National Health and Medical Research Council Center of Research Excellence. Luke is also a program manager at the Hunter New England Population Health, where he is responsible for overseeing the implementation of obesity prevention services to a geographically diverse population in New South Wales. His research seeks to address the modifiable risks for chronic disease through development and testing of public health interventions and strategies to implement them at scale. And his notoriety and his expertise is well known in our field, as can be seen by our registration today. We've exceeded capacity. And so if you have friends that are saying, I can't get on the webinar, well, you can certainly direct them to the YouTube link. It is being streamed live there. And we are so grateful to have Dr. Wolfenden join us. And so without further ado, I'll be turning it over to him.
Thanks, Taren. I'll just share my screen. And I'll get the presentation going. So look, thank you very much, Taren, Teppy, Nicole and Antonio, and thanks to the SIG for the invitation to present today. As Taren mentioned, I'm presenting today on conducting randomised implementation trials. And implementation science itself is an emerging discipline, and it's really important that randomised controlled trials for any discipline, any health and medical discipline, are undertaken well, given the place that randomised trials sit in the evidence hierarchies. And while there are certainly many good examples of randomised implementation trials that have been undertaken, broadly speaking, the quality of implementation trials is highly variable. And so one of the purposes of this presentation today is to, I guess, consolidate some of those key kind of seminal methodological text about how to do randomised controlled trials, and merge those with some emerging implementation science methods conventions that have I guess, taking hold in the implementation science community. So bringing them together with established randomised control trial methods in order to provide some guidance for the field so that we can, I guess, ultimately improve the quality of the evidence base. So I'll make a start. I guess I'm assuming that viewers of this presentation have some experience in conducting randomised controlled trials, but maybe more new to implementation science. And so I guess that's the perspective that I'll be taking as part of this presentation today. Also, the focus is on randomised controlled trials specifically. We certainly realise that, you know, there's lots of, you know, there's a great variety of trial designs that are applied to answer implementation questions. However, we're focusing today specifically on randomised controlled trials. And I should also mention that, you know, this is the presentation today will be about 40 minutes. And so the aim really, I guess, is to provide a broad and possibly somewhat superficial covering of, I guess, the key recommendations for conducting randomised controlled trials in implementation science. We're not able, I guess, given the time constraints, to go into significant depth on any one particular issue, but what I'm really hoping to achieve is to provide broad guidance and signpost some really useful texts and other resources that people can kind of refer to get more information as they're required. Okay, so I'll start with a little bit of terminology so that we're all on the same page as part of this presentation. So evidence-based interventions are the intervention or the practice, model of care, the program, the policy, or the guideline that is subject to implementation. So it's the thing that's being implemented. And when I talk about intervention as part of this presentation, I'm really talking about an evidence-based intervention. Implementation science is the study of methods and strategies to promote the uptake of evidence-based interventions as a way of improving health. Implementation strategies are methods or techniques that we use to enhance implementation. Implementation outcomes are things like processes of care or quality measures to assess the effects of an implementation strategy. And an implementation trial, which is really what I'm talking about today, tests the effects of an implementation strategy on implementation outcomes. So how do implementation trials differ from conventional clinical trials? Well, the purpose of a conventional clinical trial is really to establish the efficacy of an intervention. And so it might test things like a therapy, a surgical procedure, a medication, or a public health program like a physical activity initiative, typically on individual measures of patient health outcomes or disease. An implementation trial, however, in an implementation trial, the efficacy of the intervention is already known. So we should really be starting from the point of having an existing evidence-based intervention. And what we're really interested in testing in an implementation trial is the effects of an implementation strategy. So it's what we don't know in an implementation trial, and the purpose of that is that we don't know the effects of the implementation strategy on the outcome. So an implementation trial might assess the impact, for example, of something like ordinate feedback or training or professional reminders on outcomes of quality of healthcare, of use of clinical practice guidelines, or the implementation of a nutrition or physical activity program in schools by a teacher. So I guess just to underscore this point some more, because I think this is a really important point to get clarity on in order to get a handle on the rest of the presentation. The focus of a conventional clinical trial, and this is a logic model of a workplace-based health promotion intervention. So a conventional clinical trial would really be interested in the relationship between the intervention and the impact of that workplace health promotion intervention on employee behaviour. And so it might measure things like dietary intake or physical activity or tobacco use. The implementation strategy and the implementation itself often isn't a priority issue or a primary concern for a conventional clinical trial, and that's because they are largely under the control of the researchers. Implementation trials, however, are explicitly interested in the relationship between the implementation strategies that are used and how well implementation occurs in that setting. They're typically undertaken in more naturalistic environments. And while at times implementation trials may also measure the effects on individual outcomes, so in a workplace example, may also assess whether the implementation strategy achieved sufficient implementation to achieve a improvement in employee health behaviour, and that's typically not the primary focus. Implementation trials that do assess individual level outcomes are called hybrid designs. And the reality is that conventional clinical trials and implementation trials kind of sit on this continuum, and there's a lot of work that happens in between where where trialists do a little bit of both, a little bit of testing of a intervention, as well as the collection of information or testing of an implementation strategy. And a really useful article published some time ago by Taren describes or developed a typology for effectiveness implementation hybrid designs. And so the typology classifies these hybrid trials into three types. The first type, or type 1 hybrid trials, are primarily an effectiveness study, and so they're primarily interested in testing the effects of the intervention on individual level, health-related outcomes. And they don't typically test the effect of an implementation strategy, but they might describe or collect information about how the program or the intervention was implemented so that it can inform the later development of an implementation strategy. Hybrid type 2 trials have a dual primary focus. So they have both co-primary outcomes, and they're looking to simultaneously test the effects of an intervention on individual health-related outcomes, as well as the effects of an implementation strategy on implementation-related outcomes. And hybrid type 3 effectiveness implementation trials have a primary focus on testing the effects of the implementation strategy on implementation outcomes, and they may not test but be more likely to describe or monitor the effects of the intervention on individual or community health-related outcomes. And I guess my experience of the literature to date has been there's been enormous uptake of this hybrid typology language, but often in my experience, this is being misused in the literature. And so I guess getting a good handle on the type of hybrid that you might be interested in undertaking, and an appreciation that all of these trials operate on a continuum, I think would serve the literature really well. And when is an implementation trial warranted? So I guess there's three primary preconditions for an implementation trial to be undertaken. The first is that that you should have an established intervention that is known to be effective, ideally from the results of a systematic review. So you have an established evidence-based intervention, but you also have an evidence practice gap. So there's some kind of verification that the evidence-based intervention isn't already occurring routinely in practice. And finally, that there's equipoise regarding the effects of an implementation strategy in improving the implementation of that intervention. That is, that you don't, there isn't already an existing implementation strategy that could achieve routine implementation of that evidence-based intervention. And so this is kind of a schematic that we often use to kind of guide decisions about whether we should be conducting an effectiveness trial or whether indeed an implementation trial is warranted. Okay, so the rest of the structure of the presentation will kind of talk you through almost like the key headings of a published randomised implementation trial. I just wanted to first start with a bit of a discussion about research ethics. Implementation trials meet the definition of research and therefore invariably require institutional review board or ethics approval. However, the multi-level and naturalistic nature and context that implementation trials typically occur can really complicate ethical considerations. Often, for example, implementation trials are looking to modify systems or professional behaviour, and that these might have an impact on, on patients, on pupils, or on others that, other constituents of organisations that are receiving a service or care. And it can be complicated to know, well, who here is the participant of this trial? Is it those who are exposed to the implementation strategy? So if we're looking to modify a clinician's, a clinician's professional practice or a school teacher's professional practice, do we require informed consent from them, or is it the patient who is exposed to changes in how an intervention might be delivered? Or is it the administrators of organisations like department heads of hospitals or principals of schools that consent is required? And often consent is required at each of those levels. And there's no clear document or guidance that we can find specifically for implementation trials. There's been a few texts on implementation science and ethics in the conduct of implementation science generally, but we note that the Ottawa Statement on the ethical design and conduct of cluster trials actually deals with a lot of these issues, and is probably to date the best resource that you should refer to when you're trying to get a handle on the ethical implications of conducting implementation trials in these types of naturalistic settings, and from whom and how consent should be gained. So I'd recommend you look at the Ottawa Statement. Okay, so like all randomised controlled trials, randomised controlled trials that test an implementation strategy, typically will have a primary and secondary aim, where the primary aim is really looking to assess the effects of an implementation strategy on the outcome that is of greatest importance. And you might have a range of secondary outcomes that look to also assess the effects of the implementation strategies on other outcomes that you think are important. You should also have hypotheses that are testable research questions that are relevant to the type of randomised controlled trial that you're undertaking, and an aim which provides a precise statement about the objective of the trial, that includes information about the population, the implementation strategy, the comparison, and the outcome that's under investigation. So the STARI reporting guidelines for the conduct of implementation trials recommend that in the statement of research objectives or aims, that you clearly distinguish between the aims of the implementation strategy and the therapeutic intent of the intervention, or the thing really that's being implemented. And to try and, I guess, make this a little bit concrete, as an example, the primary aim of an implementation trial could be to assess the effectiveness of audit and feedback, which is your implementation strategy, relative to usual care, which is your implementation comparison, for improving clinician, which is your targeted population group of that implementation strategy, provision, which is the implementation outcome and the target of that implementation strategy, of nicotine replacement therapy, which is the clinical intervention. So if you are undertaking a hybrid trial, so you were actually interested in the dual effect of the intervention and the implementation strategy, you'd also add to that objective a statement which picked up your interest in the assessments of the effects of the intervention. So that might include the addition of that the aim was also to assess the effectiveness of nicotine replacement therapy, which is the clinical intervention relative to usual care in improving smoking cessation, which is really the therapeutic outcome that you're looking to achieve via the clinical intervention among cardiac inpatients, who would be your therapeutic population. Okay, in terms of sampling, recruitment and retention strategies, again, one of the complicating or complexities of conducting implementation trials is that you often have multiple participant groups, and they can be at both the individual and organisational level. And importantly, given the naturalistic context of implementation trials, we're really looking to maximise as much as we can the external validity and generalisability of the findings of implementation trials. And so I guess we want to maximise participation, like I guess we do in all randomised controlled trials, to reduce selective non-participation bias. But the emphasis on external validity for implementation trials is paramount. There's actually been a large number of systematic reviews and research to include in reviews of strategies to enhance the recruitment of patients in clinical trials, for example. What we don't know, I guess, is, and what there hasn't been a lot of research on, is, well, how do we recruit and retain, organisations or clinicians, or school teachers, the individuals that are subject to the effects of an implementation strategy. How do we engage them and increase their participation in implementation trials? And while we can draw on the evidence base for participation methods in clinical trials, it's likely that the motivations for participating in an implementation trial, particularly of managers of organisations that we need to enrol, are likely to be much different to the motivations for a patient, for example, or a community member to receive a medication or to be enrolled in a physical activity program. And so while there's lots of these are the key findings of systematic reviews on participation and participant attrition strategies in the clinical trials literature. I guess the best we can do at the moment is have a look to see whether these sorts of strategies may also be useful for the various population or participant groups that we're looking to enrol in our randomised implementation trials. And the other recommendation, I guess, is to work closely with your partners or your stakeholders in your implementation trial to develop recruitment and retention strategies that they believe will be effective. So kind of engage in some of those co-production processes. Okay, in terms, there's a large number of methodological texts that do a really good job of articulating the methodological merits of various randomised controlled trial designs. And so I won't go into these here, but I have included some of the references there at the bottom of the slide. However, I will just allude to a couple of important considerations for these different randomised trial designs for implementation trials specifically. So for randomised, parallel group randomised trials where individuals are the level of randomisation, that kind of conventional randomised controlled trial, which dominates the medical literature, is actually quite uncommon in implementation trials, and that is because many implementation trials involve testing an implementation strategy that requires modifications to systems of care, and where the risks of contamination of that implementation strategies across, for example, teachers within a school or clinicians within within the same outpatient clinic or hospital is difficult to prevent. And so, there are certainly some examples where individual level assignment works well for implementation trials. It may be, for example, that you can randomise individual clinicians to receive audit and feedback, and measures of their corresponding changes in professional practice or behaviour are easily captured and unlikely to be contaminated. But often, often individual assigned randomised controlled trials are at too great a risk of contamination, and so a common randomised method is the use of cluster assigned designs. And that's really essentially because we can protect against contamination, or do a better job of protecting against contamination. The use of step wedge designs are also common and increasingly common, and that's often because of the requirement for a fewer number of clusters, and often step wedge randomised controlled trials, or the stepping out of the intervention as part of those trial designs can be consistent with how programs or quality improvement issues are rolled out across regions or sites, which can make that design an attractive opportunity to use, an attractive design to use. But it's important to know for these types of designs, data collection can be quite onerous if you don't have outcome data that is already routinely collected. And I think for public health, and particularly community-based interventions, this is often, often very difficult. They may be easy to run in clinical settings where professional practice is often collected routinely in, for example, medical records. Factorial randomised controlled trials aren't particularly common as a design used in implementation trials, often because the absolute requirements for sample size are typically quite large, but I think they hold an important place in the literature, in the discipline, in order to help us identify mechanisms of action, or help us to compare the relative merits of different implementation strategies, which I think would be really valuable, but obviously there are design challenges there. And the use of adaptive designs like smart trials, are again a really novel innovation, and appropriate for the development of adaptive implementation strategies when there is good control over the delivery strategies and the points of assignment can be clearly articulated. Okay, so we'll move on to the use of theories and frameworks in the development of implementation strategies and overall, I guess, logic models for our implementation trials. So implementation trials should really include an explicit program theories, which describes the rationale and the assumptions about the mechanisms that link your implementation strategy to other processes and inputs and outcomes of the research trial. And so, I guess a way of thinking about this program theory is trying to, use theory and frameworks to develop a logic model and a program theory that can help you explain how the intervention or the implementation strategy has had an effect, and really should provide the basis or the skeleton for trial evaluations. So, once you have a clearly articulated program theory, then it becomes much easier for you to identify what you need to measure and how that best might be measured as part of your randomised controlled trial. So you can use informal theory, and that's essentially understandings of the problem and its determinants through experience or tacit knowledge. And this is a really important component of developing program theories that have some external validity. And we need to develop informal theory by consulting and engaging and co-producing with our stakeholders who have a far greater understanding of how things work within their setting and context than the simple application of a formal behavioural or implementation theory. But of course, you can also use behavioural and implementation theories or frameworks. However, it's probably recommended that you use both informal theory and formal behavioural implementation theories to ultimately develop your program theory to develop and test your intervention or your implementation strategy. So in terms of using theories and frameworks, there's a great paper that I'm sure has been very well cited in implementation science, which describes implementation theories, models, and frameworks. The reference again is at the bottom of the slide here. But Nielsen kind of groups, classic theories and implementation theories as really useful theories to help you develop and importantly describe mechanisms of change of behaviour or of implementation. So classic theories have been derived from disciplines like behavioural science and psychology, and they're kind of the well-established theories like the theory of planned behaviour. And implementation theories are typically adaptations of classical theories that have been, developed, I guess, to really, get into theories that are more applied to implementation problems. So they may be more, for example, interested in changes in group behaviour. Both classic and implementation theories are really useful because they provide linkages between theoretical constructs and the behaviour change or the implementation that you'd like to see occur, and that provides you, those links help you to identify a mechanism, and you might use one or more of these classic or implementation theories depending on your circumstances in order to develop your overall program theory. It's common also to use determinants frameworks. So this are frameworks like CIFAR or the Theoretical Domains Framework. And determinants frameworks are essentially consolidations of classic and implementation theories that can help you identify factors that might be associated with implementation and help you select implementation strategies that may best be used to address these. Your linkages, however, aren't specified in determinants frameworks, and so you'll need to, in your program theory, describe those mechanisms of change or create those linkages yourself. In terms of how we apply formal theory, again, there's a number of really good papers out there that describe the application of formal theory in the development of implementation strategies. French provides kind of a simple 4-step process where we first identify which individuals or professional groups need to do what differently in order for implementation to be improved. And then we use formal and informal theory or frameworks to identify barriers or enablers that need to be addressed in order for that targeted behaviour or that implementation to be improved. And then we use those theory and frameworks to select implementation strategies that are kind of matched to those barriers or facilitators. And we do that in a way that makes sure that they're effective, that they're locally relevant, acceptable, and feasible. And then finally, we decide on how we might evaluate or assess the effects of those implementation strategies. And I'll just provided a reference here, which is, I guess, a good description of how that kind of method has been applied to a physical activity study. This is a protocol for a study that was led by Nicole, and it was looking to enhance the implementation of physical activity policy in schools. And so Nicole describes who needed to do what differently in order for that to occur. And in order to then identify barriers, Nicole applied the theoretical domains framework. So that was the framework Nicole used to help her identify barriers and enablers to address or to improve implementation of the school policy. She first did that by looking at the literature. So there was a systematic review which used the theoretical domains framework as the synthesis framework for that. And that literature review identified things like the lack of time and perceived lower priority of policy implementation as important barriers. And Nicole could then match those barriers to the theoretical domains framework domains in order to help her then select implementation strategies. However, it's important when you're undertaking this work to not merely rely on the literature, and interviews and observations that were conducted in the field by Nicole and her team identified additional barriers. So knowledge of the policy, for example, or personal attitudes towards it, and it identified additional domains. And so I think this is a good example of the importance of, I guess, triangulating and using multiple methods of formative evaluation in order to have a really good handle about on what's occurring in the context and what the actual barriers to implementation of a targeted policy or practice might be. So, you know, implementation science and implementation, and particularly the formative evaluation to develop implementation strategies, is not really a desktop activity, and you really need to get out and about and understand context and observe the situation for yourself if you're interested in developing implementation strategies that are most likely to work. So important to have multiple sources of evidence to appropriately apply these theoretical frameworks. And then many of the determinants frameworks, like the theoretical domains framework, have matrices like this one, and based on the barriers that were identified, you can use these matrices to identify what implementation strategies could be implemented or could be used in order to improve implementation of that targeted behaviour. So in this case, it was a physical activity policy, and Nicole used the theoretical domains framework matrices to select a number of techniques or that were employed in implementation strategies to overcome those. There's also a variety of other resources that you can use to select and apply theory or frameworks. This is an interactive web resource that is really useful. It includes a large number of, and certainly the most prominent, dissemination and implementation theories and frameworks, and walks you through a process of whether and how these may need to be adapted for your specific implementation issue, and can help you identify measures to assess, ultimately assess the impacts of those. Okay, I'll just move on now to trial outcome measures and process evaluation. So again, like any randomised controlled trial, you know, we should be selecting measures that are directly linked to the primary and secondary aim. And if we're doing a hybrid trial, then we need to include measures not just of implementation outcomes, but individual level clinical or, you know, population or public health outcomes. And these outcomes should be, you know, psychometrically sound if they're self-report, have evidence of validity, and be sufficiently sensitive for use in a randomised controlled trial. Proctor proposed a taxonomy of 8 conceptually distinct outcome measures, and this has been an incredibly influential paper in the field. From a randomised controlled trial design standpoint, however, kind of collectively labelling these measures as outcomes has been a bit of a misnomer, and it's created some confusion in the field, as many of these measures don't lend themselves to the calculation of an effect size. So, for example, the acceptability of an intervention or an implementation strategy can only be measured within one group of a randomised controlled trial, and that's the group that's been exposed to that intervention or implementation strategy, not the group that hasn't. And so, you know, many of these measures, so this has been a useful, clearly a useful contribution to the literature, but I think the art here is identifying which of these types of measures should sit in which part of your randomised controlled trial design. Are they primary or secondary outcome measures that assess implementation effects, or are they measures of, implementation processes or other measures that are useful to interpret the overall impact of your implementation strategy? And Heather McKay has done a good job in the field of physical activity and nutrition to discusses this issue and make some recommendations about where these measures might fit in the context of doing implementation and scalability research. Most primary outcomes of implementation trials will be a measure of the degree to which the implementation strategy has achieved implementation of the particular intervention, policy, practice, program, guideline. And these obviously will vary depending on what the intervention is and what the setting is and what the guideline says. And so there is not a single standard measure of implementation that can be used across trials, like there is, for example, for physical activity trials that are interested in assessing physical activity. We can use accelerometers, and they can be done in a standard way and be pooled in meta-analysis. That's actually not the case for implementation trials. Often the primary outcome needs to be developed specifically for the research trial that's being undertaken. And given that, it's really important that we have measures that are as objective as possible for that particular implementation or improvement outcomes that we're interested in. But does create enormous headaches at the point of synthesis when we're looking to say something collectively about the effects of particular implementation strategies. This was the paper by Heather McKay that I mentioned before, certainly well worth a read, particularly for those in the field of behavioural nutrition and physical activity. In terms of process evaluations, the MRC recommends that the key functions of process evaluations include assessment of processes, mechanisms, and contextual factors. I need to also give a shout out here. The focus of this presentation is very much on quantitative methods in randomised controlled trials, but that is not in any way to diminish the important contribution that qualitative methods have in understanding and assessing the impacts of implementation strategies. And the Qualitative Research and Implementation Science Group has an excellent resource that discusses in more detail how to apply qualitative research methods in implementation science generally, but also in trials. And qualitative methods are particularly important in process evaluations. So assessing implementation processes could include assessments of, how, what, and by whom implementation strategies were delivered, and the dose that was received, any measures of co-intervention or co-implementation support, I guess, any adaptations that may have occurred as part of the delivery of the intervention or the implementation strategy. This idea of adaptations impacting on the effects of interventions and implementation strategies has received a lot of attention in the literature, particularly recently. And there's been calls for us to acknowledge adaptations as common, including in research trials, and that what we need to do to better understand and to better record and understand how they might impact on the outcomes of implementation initiatives is to code and record and report them in a standardised way. And the Sturman article I refer to here provides a detailed description of how that's best done. And in implementation processes could also include measures of things like perceived acceptability or appropriateness of the intervention or the implementation strategy. Okay, I'm moving through now. And the second component recommended by the MRC is assessing mechanisms. And mechanistic evaluations are really important because they help us to understand how an implementation strategy had its effect or didn't, and how ultimately how it can be replicated and improved. So unless we can test and understand the causal pathways of our interventions and our implementation strategies, then it's very difficult to add to this, add to the evidence base and ultimately improve the impact of our implementation approaches. So the mechanisms of impact should really test the assumptions that you specified in your program theory, and in particular, require the specification of those strategy mechanism linkages. Some of the, if you're using classical implementation theories or frameworks in the development of your program theory, a number of these will have existing validated measures of the theoretical of their theoretical constructs, like the theoretical domains framework, for example, and these can be really useful if you're looking to assess mechanisms because you have measures at hand there. But I did want to point you in the direction of a paper that was recently published by Cara Lewis, who's thought a lot about how we should best be examining mechanisms as part of our implementation research and in implementation trials specifically. So Cara talks about the limitations of the current quantitative approaches and provides some really good analytical, I guess, ways forward for how these can be improved, and also makes mention of the importance of qualitative or mixed methods for mechanistic evaluation. So that is a fantastic resource. And finally, the final component, process evaluations according to the MRC, looks at implementation context, which are the factors that may influence the effects of an implementation strategy. And understanding context is really important in order to assess the applicability of the findings of that implementation trial to your context. And it could include assessment of a range of social, political, economic, environmental factors. For example, workforce capacity or readiness to change. Other implementation trials in nutrition, behavioural nutrition and physical activity have assessed macro level factors like policy changes or changes in regulation or financing, or the introduction of new guidelines that have had an impact at a setting level where a program or policy was being implemented. And they've done that through assessing, for example, government websites and newspaper reports in order to identify things in that broader environment that may influence implementation. So descriptions of context are typically descriptively and not analytically presented in randomised implementation trials. There's a couple of resources here if you're looking for measures to include in your implementation trial. The most comprehensive is the Society for Implementation Research Collaborations Instrument Review Project, which is the image on the left there. I'll talk briefly about sample size calculations and reporting, then I think that's the end of the presentation. I'm conscious of time. I guess the key thing to say for sample size calculations for implementation trials is that, unlike conventional clinical trials, the perspective of sample size calculations for implementation trials should be considered from the perspective of the health system rather than the biological or clinical improvement at a patient level. And so sample size calculations and justification should be ideally justified on the basis of health system improvements. And finally, reporting, we should be reporting our implementation trials consistent with standard methodological conventions like the consort guidelines and any specific extensions. We also have specific guidelines for reporting implementation trials. They're called the STARI guidelines, and they're intended to be, I guess, an adjunct to things like consort. And the STARI guidelines really emphasise the importance of reporting in a replicable way, both the intervention that is being implemented, and so that you can use checklists like TIDIA for the description of the intervention, as well as the implementation strategy that's being tested. And there are established taxonomies like the ERICS taxonomy that should be used when we're describing the implementation strategies that we're testing. And I just wanted to acknowledge the large number of individuals listed here, too many to list, too many to name, that contributed to the content of this presentation, and a publication that we're hoping will be publicly available soon that provides more detail into what I presented today. Thank you very much.
Thank you so much, Luke. We've had wonderful engagement on Twitter, so get onto that if folks on the webinar if you'd like to see more of that discussion, but also some questions coming in two ways. One, Tepi is monitoring what's coming through on the YouTube channel, and Nicole is monitoring what's coming through on the Q&A here. And so I will turn it over to them to moderate our Q&A.
Thanks, Taren. Thanks for that, Luke. That was great. So we've had a question from Karen Milton. She said, what are your views on studying implementation of interventions of unknown effectiveness? Should we always establish effectiveness first?
It's a good question. I mean, I think that studying the implementation of interventions that we don't know are effective can still contribute to the implementation science literature. And so they can still provide new knowledge about how we might change a teacher or a childcare service, a director or a clinician's professional practice, so they can generate new insights. I think it's the ethical considerations that really need to be thought through about undertaking evaluations of interventions of unproven effects, because often implementation trials involve, as I mentioned, changes to systems, and we want to be changing systems of healthcare or of health promotion when we're confident that they provide a benefit to the community. And so I guess I'd be cautious about, I certainly wouldn't undertake a trial I wouldn't undertake an implementation trial if I didn't know the effectiveness of the intervention. However, it may be an opportunity if an intervention is being rolled out anyway, and it's going to happen anyway, then there may be an opportunity to learn something from it in that case, but it's certainly not something I'd set up as a researcher.
Brilliant, thank you. Okay, so inevitably we've got a question about the impact of COVID. So this is from Kwok. In terms of running trials now and in the context of COVID-19, we suspect the expected outcomes were influenced by the change in lifestyles due to COVID-19 restrictions. Where would you start in terms of examining the outcomes and implementation strategies given those circumstances?
Yeah, well, it's a good question, and I think I'm not sure I don't think anyone knows the right answer to that question. I think it's really unclear about how COVID has had an impact on behaviours and how they may have behaviours of individuals, so health behaviours of individuals, but also behaviours of providers. Like, it's been an incredible state of flux that the whole world is experiencing at the moment. And I think probably what it's safe to assume is that the generalisability of evidence that is produced over a period of COVID, may not be great. And so, I think, unfortunately, I think that, a lot of the work that's being undertaken at the moment that is impacted by COVID is being undertaken in circumstances that we're probably not going to see again for quite some time. And so I guess there could be limited generalisability of that type of work, and perhaps it may be better, depending on the research that you're undertaking, to down tools for a while until there's context that exists where you think that the research might be better placed to make a more direct contribution.
Yep, let's hope, Luke. Okay, so we've got another question about, we've got a question here about sample size in implementation trials. So for effectiveness trial and hybrid type 1 and 2, the justification of sample size could be based on achieving estimates of sufficient precision. What about trials assessing implementation outcomes only?
Well, I think it's the same. So I'll just say that for hybrid trials, hybrid type 2 trials, we have a co-primary. You'll have to have a sample size calculation that is more conventional. So it's looking at clinical meaningfulness of an effect size at an individual level, because that is one of the primary outcomes. And you may achieve that by nesting that individual level outcome within a broader research trial design. So you may have a nested assessment of those individual impacts within a broader study that includes more sites, and that's certainly common. Certainly we have undertaken that type of nested design in our trials. In terms of implementation outcomes, I think estimating outcomes from health system perspectives and providing a measure of precision is probably the best. That is what you should do. I think you should, if you can, establish a threshold from a health system perspective about what would be meaningful improvements in the provision of healthcare services. So that could be from a health point of view, or it could be from a resource use point of view, or cost or perspective. And so, like all sample size calculations, those calculations should include an estimate of precision that's meaningful to the end user or the people who are going to ultimately make decisions based on the outcomes of those trials. So the the way of calculating the sample size is the same. It's the perspective that changes, I guess, is the key point.
Okay, thanks, Luke. Okay, so we've got a question around cost effectiveness in implementation trials and whether it's commonly investigated.
Was that from Penny? A colleague asked me to talk about economic evaluation in this presentation, but it's certainly not my field of expertise. And maybe we can have a health economist come and present a follow-up to this presentation to talk about that in more detail. I think I can say confidently that economic evaluations of implementation trials is very uncommon. I think I could count on one hand the number that I'm aware of in the field of behavioural nutrition and physical activity. So it's very uncommon, like it is, I guess, for conventional effectiveness trials of public health interventions. And so, you know, the field could certainly use more economic evaluations.
Okay, thanks, Luke. I've got a question from Heather. How do you establish sample size if you're conducting an RCT investigating implementation strategies?
How do you determine sample size?
How do you establish sample size? Yep, if you're conducting an RCT in implementation strategies.
So I think the process is the same. So you need to identify an effect size on an implementation outcome that is meaningful for your end user, and then based on that difference between groups and the measure that you've selected to assess it, you need to make sure that you've got adequate power and sample ultimately in order to detect that difference based on some assumptions about variability, for example, or baseline prevalence. I think the issue, the complexity can be, is that often you don't know about how much the level of, you know, there's some extrapolation often involved in identifying that system level beneficial impact. So what is the beneficial impact from a provider level? That can be difficult to determine and often involves some extrapolation between the level of implementation that you're expecting to achieve as part of your implementation strategy and how that might follow through into improvements, for example, in resource use or population level health outcomes. And so so that can be difficult, is making that link between the level of implementation and the ultimate outcome on that the provider is interested in. And that, I think that is a challenge, and that can take some extrapolation, or there's certainly some assumptions involved in that. You typically wouldn't have the data to do that, not robustly, but confidently. You know, you'd be super confident in that.
Okay, thanks, Luke. So we've got 3 more minutes. I just want to make sure, Tepi, is there anything before I keep going on the YouTube questions?
Yep. So we've got a question from Anna Barbosa. How we manage blinding in implementation trials?
Yeah, it's a good question. I guess like many kind of public health interventions, blinding is particularly of those receiving the intervention or an implementation strategy is difficult. You know, we can't use placebos, so typically that those receiving will be aware. I guess we can continue to blind outcome assessors, those that might be involved in the recruitment of individuals using techniques that we would also apply in clinical trials. But, you know, blinding and the bias that might be inherent in the lack of blinding of those receiving the intervention or the implementation strategy is, you know, is certainly an issue that many trials probably aren't able to overcome, just given the nature of the exposure.
That is it from the YouTube questions. There was just a question about whether there's going to be recordings made available. And yeah, the recordings will be made available on the ISPAH website and the ISPAH website as well.
Okay, so we've got about 1.5 minutes before we're going to have to wrap up. So Luke, we might just have time for one more question. I'm just going down the list. So we've got Jasper. He asked about for interventions where the results are very dependent on implementation, or where you want to experiment with different types of implementation. So I think this must be jumping off from something you've been talking about. Am I missing part of it? Okay, I might have to, I've lost where that one came from. And another question about when considering mechanism of behaviour change, are you referring specifically to the intervention, i.e. the program and the recipient of the intervention, or also the behaviour change associated with the implementation strategy, i.e. the health professional?
That's a great question, because it could be either, particularly for hybrid designs. But ultimately, your program theory should almost plot, you know, from the point of the intervention and implementation strategy right through the implementation outcomes and ultimate improvements in health. And, you know, a comprehensive program theory would do the lot. And you could test any of those linkages. And in fact, I think something that has been lost in the petitioning of intervention and implementation strategy is the fact that an implementation strategy in its own right could act as an intervention. And, you know, the same interventions supported by different implementation strategies could well have different effects on behaviour or on outcome. And so I think the answer is it would be great if someone could, you know, actually test out some of these, test out some of these assumptions that we're making about our program theories and try and actually link implementation strategies and the intervention to the ultimate, you know, behaviour. So you can do both. It would be amazing if people did, because I think that would really move the field forward.
Okay, I think we're right on time there, and Taren, we need to wrap it up now. Is that right?
Yes, I think so. But what a wonderful time together today, and what great engagement from the audience. We appreciate each of you so much, and appreciate our panelists today for their time, and also, of course, Dr. Wolfenden for just a wonderful presentation. And as Sebi mentioned, these recordings will be made available, and I encourage everybody to share them, because there's just some great seminal text reviewed in these slides that Luke shared today. So what a great resource we can share with our colleagues. Thank you all. Antonia, anything further from you?
Thank you so much to everyone. Give us a day or two and we'll post this on our websites, okay?
Thank you all so much.
Thanks, everyone.
Okay, bye-bye.
Bye.
Great, guys.